As Denise mentioned, I'm glad to be here. I hope the weather is as good where you are as where I am. I'm in Cleveland, and it's like summer today. It's 80 degrees, very sunny, and we'll take it. It's been a rough winter per usual. So let's get started. I'm going to try to move this thing here. Hang on one second. I hope this doesn't do anything bad. Okay, that's good. All right, I got it. Sorry about that. I had some things appearing on my screen I needed to get rid of so I can see it. All right, so today I'm just going to really talk about the basics of EHE. And for a lot of you, you probably know a lot of this stuff, but I'll try to add my own spin where I can. First of all, that people need to understand, and probably most of you do, is that this isn't what we would classify as an ultra rare cancer, in that the estimated incidence is less than 1 in 1 million people. So super rare. And most of you kind of run into this when you had your diagnosis, or your family member had the diagnosis, and the doctor who was responsible for the biopsy, whatever, said, you know what, I've never even heard of this. And I actually get a lot of phone calls and contact from people at that stage where they say, well, my doctor doesn't even know what this is. What do I do? So let's go into the name. So epithelioid hemangioendothelioma, we say EHE, we say this all the time, but what does it really mean? So I'm a pathologist, and EHE was described by pathologists. So all it really means is epithelioid, the cells are round. So this is a tumor that has round cells. And hemangioendothelioma is a cancer with vascular differentiation. So it's a cancer with vascular differentiation that has round cells. And again, described by pathologists. So this disease is slightly more common in women, and that's really due to this peak around childbearing age, where women seem to get liver lesions predominantly at that age group and are responsible essentially for where it's more common. If you look at all other age groups, it's pretty much even. The incident peaks in the 4th or 5th decade, and it's very rare in children. We do have children with EHE, but not very many, thankfully. And importantly, this disease can arise at any anatomic site. And by that, I mean it can arise in brain, liver, lung are most common, but GI tract. I mean, essentially soft tissue, bone. I've seen EHE in virtually every possible site that you can imagine at this point. There are different clinical presentations, and those different clinical presentations are important because they have prognosis associated with them. So single lesions are probably the least common, and that means you just have one lesion of EHE. And if that occurs, then that's usually pretty treatable, and there's a very high cure rate for those patients. Frequently, we have patients with multiple lesions in one organ. The most common there would be liver with a bunch of lesions in it, and we call those local regional metastasis, because all of these tumors rise from a single tumor, but they just spread. This one's spread locally. And then the most common presentation is when people present with EHE involving multiple anatomic sites. The most common, about half the patients will present with lung, liver, and or bone metastasis. And then the presenting symptoms include asymptomatic presentation. That's very common. So people get in a car wreck or have an accident, and there's pictures taken of their liver or whatever, and that's how they're discovered. About 40% of patients present with pain. You can have a palpable mass, so that means that you can feel a mass, usually in the soft tissues, or weight loss. So I will say that many prognostic factors have been proposed, but none are really well validated. And I believe you're going to hear later on today from a young oncologist from the University of Washington, Michael Wagner, who's going to talk about some work he's been doing looking at registries of cancer patients to try to understand prognosis and some other factors pretty well. So I'm just kind of giving you a highlight about his talk. Now, serosal involvement, pleural involvement, so that's literally involvement of the lining. So lining of your abdomen, the walls of your abdomen, as well as the outside of your lungs and the cavity that the lungs sit in. That's usually a very adverse prognostic factor. And those are typically associated with what we would call a malignant effusion. And so patients in that setting tend to have a worse prognosis. Fever, weight loss, and fatigue are also associated with a worse quality of life. And many of you I know contact me and talk about the pain associated with EHE, which can be extreme and is actually very difficult to treat. Anemia can be a negative prognostic factor, so essentially associated with blood loss or a chronic disease. And then Really importantly, the clinical behavior is extremely variable. And so there are patients who present with EHE who live decades without any change at all in their disease. Other patients present and have a very aggressive clinical course. It's difficult for us at this point to predict. As I mentioned earlier, serosal involvement of the pleura and abdomen are adverse prognostic factors usually associated with pretty rapidly accelerating disease. But it's difficult for us at this point to predict who is going to progress and who isn't, and predicting things like absolute lifespan due to EHE, almost impossible at this point. Now, disease surveillance typically consists at this point, since we really need to keep an eye on everybody, of serial sequential imaging. That means we take CT scans, usually at about every 6 months, or another imaging modality to keep an eye on the tumors to see if they're progressing. And we'll talk a little bit about progressing in a second. Now, maybe the most important thing that I have to stress to you today is I do recommend management of EHE patients by multidisciplinary treatment teams with experience in treating patients with EHE. I mean, that said, nobody has that much experience treating EHE patients. Probably the best groups in the world are currently managing, 10 to 20 EHE patients, and maybe over their career have managed 50 to 100. That would be a huge load of patients with EHE for any one center. But you do want to go where people have seen the disease, understand it, understand how to manage it. And I can't emphasize that enough. So again, the pathology, and I'll show a few pictures because I am a pathologist, is an epithelioid neoplasm, and it tends to have this unusual stroma that we're actually studying the stroma right now, the microenvironment that the cells live in, to try to find some clues that we might use for therapy. Again, this is a vascular cancer, so it shows vascular differentiation. And the way we look at that is by looking at immunohistochemistry. And typically we use things like CD31, CD34, those aren't going to mean a lot to you, but a lot of people will show me their pathology reports. If you do see those markers on your pathology reports, it means it's got endothelial differentiation, and that's supportive of the diagnosis of EHE. There are two major genetic subsets. There's WWTR1 CAMPTA1 gene fusion. That's what people typically think of as EHE. 95% of patients with so-called EHE will fall into that category. And then CAMPTA1, which is the second part of this fusion, there's an antibody. CAMPTA1 is not usually expressed in any adult tissues at all. It's expressed during development in the brain. And so CAMPTA1 expression is significant. And we actually use an antibody to CAMPTA1 as a surrogate immunohistochemical marker at this point for the gene fusion. The other subset, which is much rarer, is YAP1 TFP3 gene fusion. It's really a distinct disease, very different than WWTR1 CAMPTA1 gene fusion. And TF3 is a surrogate immunohistochemical marker there, but it's not quite as good because it's just not quite as specific. We do recommend getting genetics when possible to identify a fusion. Now, again, I'm going to recommend that if you have a diagnosis of EHE, get your pathology reviewed by an experienced soft tissue sarcoma pathologist. It's very, very important. That's because EHE can look like a lot of things. And I know I've seen a lot of chat from patients over the years about being misdiagnosed, and something like carcinoma, especially breast cancer, especially something known as lobular carcinoma of the breast, can look a lot like EHE. And EHE patients occasionally are diagnosed as having lobular carcinoma of the breast and vice versa. And so, again, that's something that can really mimic EHE. Mesothelioma, especially in the abdomen, is another disease that can really look a lot like EHE. There's another super rare sarcoma called epithelioid sarcoma that can look like EHE. And then there's a litany of vascular tumors. People don't realize how many different vascular tumors there are. There are over 50 distinct entities in this category of vascular neoplasia. I just highlighted a few things that typically will mimic EHE. One's hemangioma. That's a totally benign disease. Doesn't require any kind of chemotherapy. And I did have a case not that long ago, a patient who was diagnosed with EHE. When I looked at it, it turned out to be a hemangioma. Pseudomyogenic hemangioendothelioma is another disease. It's kind of like EHE, but really it's a totally different thing. Super rare again. People can mistake that for EHE. And then angiosarcoma, which is the most aggressive vascular tumor of them all, can also look like EHE. It's really, really important to know what you're dealing with. Again, I recommend sending it to somebody who's really got a lot of experience in this diagnosis. In terms of imaging, so how do we image EHE? So baseline staging. So once you have, and most people get a diagnosis of EHE, so they've had some sort of imaging and a biopsy. Once that's occurred, then you're going to stage. And what we typically do is whole body imaging. Now, many ways to get to that. You can do CT, MRI, PET. What we use typically at the Cleveland Clinic these days is a lot of PET CT. So that's a combination of both PET and CT, so we can see the body very well. And then we can see where there's hot spots, areas where tumors have taken up glucose, essentially radioactive glucose, and identify those as sites where EHE is likely there. And it's very, very important when you get your diagnosis to have this kind of imaging to stage you, so we know which organs are involved, because it will influence treatment. And then progression is something that people are really, really interested in. And typically the way this is done is by serial CT. However, I will say that there's a variety of imaging techniques that can be used, and it really depends anatomically where your EHE lesions live and whatnot. We use CT very much because we're typically looking at liver, lungs. CT does that very well. That's what we use at the Cleveland Clinic. And what we're looking for is growth of pre-existing lesions. And so many EHE lesions will not grow. And in fact, some of them will even regress and calcify. I think they probably undergo something known as senescence, which is basically the cells going to sleep. When they go to sleep, they tend to calcify and go away. And so, however, some will grow, and we're looking for growth. So when we see growth of pre-existing lesions and that growth is definitive, we may even need to follow it for a little bit to be sure that things are growing. That's progression. The other things that would indicate progression are appearance of new lesions. And so if you take a picture of the liver and then 6 months later you do it again and there's more lesions, that also is progression. And then we count effusions. So if you have a effusion that is fluid living around the lungs or in the abdomen, that also is progression. So we look for those three things to document progression. And when we see progression, that will suggest a really big time re-review of each patient, and we will decide on whether or not there's going to be any therapeutic changes based on those progressions. So let's talk just very briefly about surgery. So the treatment of choice for single lesions is surgery. Very high cure rate, about 70 to 80% when you have negative margins. And negative margins means the tumor was excised completely without any kind of tumor around it, normal tissue, not tumor tissue. However, sometimes surgeons can't get out an entire lesion for whatever reason. It's too close to a blood vessel or whatever. And so in those kind of instances, radiation therapy is very useful in what we call cleaning up a positive margin. So you can go in there and irradiate around the tumor. And if there's tumor cells there, radiation can be quite effective in keeping the tumor from recurring. Surgery can be substituted by radiation therapy and ablative procedures for isolated lymph perfusion if surgery is not possible. So just to say, again, this is why you want to end up at a multidisciplinary sarcoma group, somewhere with a lot of experience, because they have experts in every single one of these areas and really can decide on what is the absolute appropriate therapy for you. And you are important when we help to design these therapies, because we want to know how you're feeling, what kind of things you like to do within the therapeutic modality. Some people are not comfortable having lesions within them that are being monitored and want them ablated, for instance. Other people are okay and don't mind watching them. So, active surveillance is great for some and it's not for others. And I think it's really a conversation that you have with your team. But if you really trust your team and they're experts, then I think you can get a better outcome. Now, active surveillance is not recommended for patients with resectable single lesions. So if somebody has a single lesion again, we don't recommend active surveillance. That is the initial recommendation for patients with metastasis. So multiple lesions, we recommend watching and looking at them for a bit to understand whether they're growing or whether they're indolent and not growing. Single lesion that's resectable, you can just take it right out and be done with it. Now, let's talk really briefly about liver EHE, which is one of the more, in fact, it's the most common site. Surgery is the treatment of choice for slow-growing unifocal, that means single or limited local regional disease. And it's really important to have a good liver surgeon. Can't emphasize that enough, because some lesions are resectable, others are not. And the liver is an organ unto itself, and you really, really need a lot of expertise when you decide whether something can be taken out or not and leave you with a liver that's pretty functional. Liver transplant is an option for patients with unresectable liver disease or liver failure due to tumor. Again, it's a bit controversial because nobody's ever done prospective clinical trials. I was talking to a gentleman on Friday who's recently diagnosed with EHE, and we're talking about evidence and what the evidence was for various treatments. And unfortunately, with really, really rare cancers, there are not tons of evidence. But, you know, if you were considering a liver transplant, you can talk to the folks who do that and, you know, get an opinion about whether or not it's something that might work for you. Stereotactic body radiation therapy and radiofrequency ablation are also useful for unresectable lesions, and that's been done a lot in the liver, not just with EHE, but all sorts of lesions. And so people are very comfortable these days, you know, essentially ablating a lesion using one of those modalities. And then just in terms of EHE, the lung square, which is the second most common anatomic site, it usually is associated with, you know, more systemic disease. And then pleural effusion, or pleural involvement with effusion, as we've mentioned a bunch, is associated with a worse prognosis. Surgery would be the treatment of choice for a single lesion, but if you have more than one lesion, you really got to talk about it. So radiotherapy, now there's very limited evidence of using radiotherapy alone to treat EHE as a primary modality. It's been mostly used to help with things like pain when you have positive margins and so forth. And so again, you want access to a good radiotherapy team, and you just have to use it on an individual case assessment. The major consideration there is surgical resectability. In terms of EHE as a systemic treatment, so for patients with asymptomatic metastatic disease, active surveillance is the preferred approach. For patients with effusions and or marked systemic symptoms, systemic therapy should be considered. For patients with metastatic disease and unequivocal evidence of disease progression and or worsening symptoms and or organ dysfunction, systemic therapy should be considered. Now, unfortunately, we don't have any generally accepted systemic therapies available for EHE. Some therapies that can be used are interferon, thalidomide, multi-kinase inhibitors, including trametinib. We did a prospective clinical trial on trametinib that's being written up and will be published soon. mTOR inhibitors, sirolimus, a lot of people have heard about as a therapy. There's some prospective or some retrospective evidence that sirolimus might be useful. I will say that participation in clinical trials is encouraged, and the trametinib clinical trial was one that I ran with a guy named Scott Schutze at University of Michigan, and I know that many patients enrolled in that. We learned a heck of a lot about treating patients in the clinical trial setting with EHE in that trial. Again, I recommend management of EHE patients by a multidisciplinary treatment team with experience in treating patients with EHE. In terms of unmet needs, now we've talked about this already. A lot of what Denise talked about are things that will really help with all of our unmet needs. So, you know, due to the unpredictability of the clinical course, the lack of effective medical therapies, research in this disease is really needed. And it's actually really hard to do because it's such a rare disease. So patient registries, as Denise talked about, extremely important. Please participate in those in registries if you can. It's very, very important to keep getting data together so that we understand the natural history of the disease. Biobanking EHE samples is incredibly important. So when you do know that you're going to have a sample that's going to be removed, be very valuable if we could freeze a piece of it or try to grow some of it. And then development of biological models is very important. Now, I realize that I'm actually looking at the wrong presentation. I'm going to launch, excuse me for 1 second while I find the real presentation for today. Here it is. Okay, bear with me for 1 second. There we go. And all right, so sorry about that. I do want to show you a picture here. So this is something I put in. This is Franz Enzinger on the left and Sharon Weiss. These are the people who described EHE. They're essentially the original folks who described that disease. And well, I didn't get to know Franz well during his career. He's a pathologist. I met him once. I did get to know Sharon very, very well. She was down at Emory and University of Michigan for a number of years, and essentially is one of the most influential people in pathology diagnosis. Here, by the way, is a gross picture of what an EHE looks like. So this is actually a slice of liver from a patient who had a liver transplant, and I was able to get a photo of it. And you can see 3 EHE lesions here in this liver that was resected. They tend to have a very hard, kind of fibrous center, and then the outside is a little bit softer. This is where most of the tumor cells live, in this outer portion of that kind of umbilicated nodule. Here's what the histology of a lesion looks like. This is a blood vessel here in the center. Hopefully you guys can see that. And interestingly, the tumor stops the middle of this blood vessel. And so there's this blood vessel has been occluded by tumor, and there's lots and lots of other tumor cells living outside of that blood vessel. This is almost a sheet of tumor at this point. And here's what it looks like at high power. And you can see the cells are basically round. This is a little cord of EHE cells. And then they form these little groups, but again, the cells are round, and then they live in this stroma, which is very characteristic of EHE. It's kind of this, what we call a mixohyalin type stroma, that when we see this picture, that's typically EHE. We can prove it. I did mention CD31. Here's some CD31 staining the tumor cells. And then again, that tells us it's a vascular cancer. Here's ERG. So ERG is a endothelial marker, again, telling it's a vascular. It tends to stain nuclei, whereas CD31 stains the cytoplasm. That's why this looks like dots. And then here's CAMPTA1 staining. So this is EHE. And here's CAMPTA1, which is immunohistochemistry, staining the tumor cells. It actually stains the nuclei and the cytoplasm. And again, that is very characteristic of EHE. So I'm just going to whip past this because we've already talked about it. Yeah, this is where we left off. And so I'm going to talk a little bit about biological models and biology, because that's what I do in my laboratory. Beyond being a pathologist, we've kind of pushed forward the biology of this disease a lot over the last 10 years. And so, we discovered the gene fusion back in 2011, and we immediately started working on modeling EHE. We didn't have any cancer cells to work with, so we worked with what's called heterologous systems, and I'm not going to go into that, but what we ended up figuring out. So TAS, which is also known as WWTR1, the gene's known as WWTR1, TAS is the protein, is fused in EHE to another protein called CAMPTA1. And TAS is controlled by something called a Hippo pathway. The Hippo pathway is a tumor suppressor pathway. That means it fights tumorigenesis, so it's anti-tumor. And typically what the Hippo pathway does is it controls the location of TAS. TAS is in the cytoplasm most of the time. And the Hippo pathway, when it's on, keeps TAS from getting into the nucleus. When TAS is in the nucleus, it actually binds to proteins called TEADs. And I will say at this point, a guy from my lab, one of the project scientists, Ajay Pabadi, is going to talk about TEAD as a target for TAS. But when TAS binds, or for this disease, for EHE, when TEAD binds to TAS, it actually allows it to be a transcription factor, and that is very pro-tumorigenic. TAS CAMPTA1 works the same way. So TAS CAMPTA1 binds TEAD. So what we learned about TAS when it's fused CAMPTA1 is that the Hippo pathway is unable to control its localization very well. It spends most of its time in the nucleus, causing EHE, and it does that by binding TEAD. This interaction is extremely important. And again, Ajay is going to talk about that in quite a bit of detail and talk about a project we have in our laboratory, as well as what progress there has been in the field to inhibit the binding of TEAD to TAS as a medical therapy for EHE. Another thing we did was a molecular dissection downstream. So this was the basis of, I talked about the trametinib trial. The reason that we thought what trametinib might be useful is that when TAS CAMPTA1 binds to promoters, it actually produces a bunch of different proteins, but one of them is CTGF, connective tissue growth factor, which is a secreted protein. It binds to something called integrins on the cell surface, and then that stimulates essentially an electrical or a chemoelectrical circuit known as the MAP kinase pathway, and that's why trametinib was so important, because it's an inhibitor of that pathway. And so that was the basis. And we actually published the science behind that in 2022 in a journal called Clinical Cancer Research. Now, early on, I worked with the EHE Foundation in the earliest stages of when the foundation was being made. And one of the critical decisions we made, kind of as a group, was that we really needed to make biological models. And so we put a lot of our effort into making a genetically engineered mouse model. The reason we did that is because I've had a lot of success doing that in my career. And it's a way that it's a relatively surefire way to create biological models that you can use to study a disease. Now, not all these models turn out. So you're actually putting a lot of faith in the idea that it's going to work. I will say, to make a long story very short, the EHE Foundation funded a lot of this work early on. We got some funding from other foundations, and I'll cite them at the end of this talk. But we were able to create a very, very accurate model of EHE. So these tumors actually carry a copy of TAS-KEAP1 in their genome, and we can turn that on. It's expressed at normal physiological levels really at any time, but we typically turn it on about a month after the mice are born, and then we follow the mice, excuse me, for various amounts of time to see if they form tumors, and essentially all of them do. And here's some gross tumors. Here's a big tumor hanging off the liver of a mouse. Here's some tumor that's kind of coating the small bowel mesentery. Here's tumor coating the diaphragm. Diaphragm is the muscle essentially that moves your lungs. And this is what the tumors look like over here on the right. Now, this is an advanced version. So we actually have two versions of the model. The first module just has TAS-KEAP1 in it. The second one, we actually removed another tumor suppressor called CDKN2A. So here's the wild type version. This is with CDKN2A. And again, I'm not going to belabor it, but you got that weird stroma. Here's the epithelioid cells. Here's when it's lost CDKN2A, and I will just say that it looks basically the same to a pathologist. It stains the same, so it stains for CD31 and ERG, those vascular markers. It's also positive for CAMPTA1. And in short, this is a very, very good biological model now. It's allowed us to do lots and lots of stuff. One of the most important things that we've been able to do is to generate cell lines, and we can actually generate pretty much as many cell lines as we want now. From these mice that have EHE with loss of CDKN2A. Here's 3 tumors that we took. We actually dissociate them. So we grind those tumors up, chuck them into a dish and grow them up. And we were able to grow them into cell lines. So here's 3 cell lines that we work with a lot: 3.6, 3.17, and 3.26. We again just published this very recently in Clinical Cancer Research. So it was a paper in January we published. Sorry, I think we already showed it. Oh, no, that's going down. Okay, there we go. Go in the right direction. And then one of the cool things we can do is actually take the cell lines are manipulable. So we can take the cell lines in a dish, and we can do all sorts of things to study the biology, but we can also inject those cell lines into mice. And when we inject them into immunocompromised mice, they grow as tumors in the mice, but really importantly, they metastasize widely. So we've got a fully functional group of biological models here, all the way from the genetically engineered mice to cell lines derived from those mice to something we call allograft mice, where we can take the cell lines, inject them into mice, and really start understanding the biology in ways that we never really thought would be possible a while ago. This is just showing here. This is a bunch of what looks to be lung lesions. So this pair of lungs is full of lesions. Here's what they look like in the lung. And again, they look just like EHE. We've got some more metastatic lesions over here in both lung and liver. And then just to close out, to emphasize the utility of this biological model. So people talk a lot about therapy, what therapy would be useful in EHE. Now that we have cell lines, and in fact, we can actually test them in viable mouse models, we can look at that. And so here's trametinib. Trametinib, again, is the MAP kinase inhibitor I mentioned very briefly. This, and I don't want you to, I know you guys aren't mostly scientists, but essentially what we do is we look to see whether the cells are growing. And when they're untreated, which is this blue bar, we say there's 100% growth. Now we start adding in mechanists at clinically important levels, and you can see that growth goes down quite a bit. 12.5 nanomolar, which is a tiny amount of trametinib, easily achievable clinically. It inhibits the growth at least 50%. And then we have some things over here that I'm not really going to discuss, but you can see it's the same effect in 3 different models. And so we know that trametinib is something that can slow down the growth of EHE. Unfortunately, it's also a quite toxic drug, and so we want to get away from trametinib whenever we can and find some better drugs. Now, MGH-CP1 is also a drug. It's a tool compound. So this isn't something that you could ever use in people, but it's a proof of concept kind of drug, and we're trying to develop better drugs in this class because MGHCP1 was developed by Dr. Wu at Mass General, and it's a TEAD inhibitor. Remember, I mentioned that TEAD binds to TAS-CAMP1. This is an absolutely critical interaction. Without being able to bind each other, TAS-CAMP1 can't function. It would be a very, very effective therapy for EHE. And you can see that in all three of our cell lines, the growth of these cell lines are inhibited by that tool compound in each case. And here we're looking at transcription. TAS-CAMP1, I didn't mention it explicitly, but it is a transcription factor. And so it shuts off transcription as well in the presence of drug. I do want to thank the people in my lab who do all the work. Specifically today, I talked about the work of Caleb, Schwan, Jai, Schwa, a little bit, some of the original studies by Munir Tanas, who now has his own lab at University of Iowa. And then here's all the different groups that fund. Notably, we have the 3 EHE foundations. I think there's a new EHE foundation in Italy now. In any case, we've been funded by lots of people that have made all this happen. I did mention Scott Schutze as well at the University of Michigan. And yeah, I hope that was sort of a good crash course in EHE. Sorry about showing the wrong presentation at first, but we got to the right one eventually. I'm happy to address any questions at this point.
All right, and Dave Kasimer joining here. I'm going to be handling Q&A with each of the presenters. And so we had a number, so just so everyone knows, we have questions coming in live as the presentation is going on. We also received quite a few questions over the previous days. And we have a Ask the Expert at the end of the session today. We'll answer many of those questions during that session, but I'm trying to select the ones most relevant to each presenter to go through. And so we got 2 questions in very recently here about the models. So the first one was sort of raising the question about what's better, mouse models or cell lines, and maybe you can kind of talk about the pros and cons of each of those 2 different systems.
Yeah, well, so I mean, and mouse models are useful because so our original genetically engineered mouse model is immunocompetent, and so we do want to know whether whether a therapy or some other aspects, like whether it's going to metastasize or something like that, things that you would need a whole mouse or a whole human. We don't obviously aren't trying to experiment with people. So mice are very useful from that respect, are useful. So for drug studies where we want to know what happens when we inject an animal with EHE with the drug. And then also when we're looking at things like, are the tumor cells moving, spreading to different organs and whatnot? Animals are very, very useful for that. But they're difficult to manipulate. And so, it took us 4 years to make that genetically engineered mouse model. If I wanted to make some minor tweak to it, it would take another 4 years. Cell lines are cool because you can take those tumors out of the gems now, out of the genetically engineered mice, grow them in a dish. And now those are really easy to manipulate. So if I want to remove a gene, I can do that very easily. If I want to mutate a gene, I can do that very easily. So I can really do a lot of things. I can also grow them in different kinds of media. I can do all sorts of things very quickly and with high throughput. And so the cell lines also have great utility. Now, sometimes people ask, well, what's better, a mouse cell line or a human cell line? I mean, honestly, human cell lines are always better because they're absolutely human, and we know that can't be any possible difference between mice when it's a human cell line. However, they're very, very difficult to grow, and I don't know. There's one cell line in Italy that may be a model, but it hasn't been published yet and hasn't been distributed, and so we haven't had a lot of experience. And we are always trying to make human cell lines, but the mouse cell lines, I will say, are very faithful. They actually do everything we want them to do, and it's nice that we can generate them pretty easily. We're actually in the process of working in different genetic aspects into our mice to try to drive new cell lines to come up with more heterogeneous lines that may represent different facets of the disease. But both are very, very useful and very, very important.
Excellent. I've got a few questions that go to some of your introductory material that you covered. We have a handful of questions that came in about locations of EHE, where they're showing up. And you briefly mentioned they can show up just about anywhere. One of our questions was specifically asking, can you see initial EHE showing up in the brain?
Yeah, I've never seen a primary case of EHE, presenting with EHE of the brain. In fact, EHE of the brain, in my experience, is extremely rare. There are definitely validated lesions that have been diagnosed in the brain, but I would say it's a rare site and I've never seen it as an initial site. That said, I do think it could happen.
So if you do see it in the brain, it would typically be a metastasis to the brain?
Yes, that's been my experience.
And do you see, from not a primary tumor standpoint, but a metastasis, those can end up anywhere? And we had one specific question where someone initially had EHE in the pelvic region, and they were wondering, can it metastasize to places as distant as, say, the feet?
Yeah, it could. I mean, it's super rare. Typically goes to liver, lung, bone. Those are your three, far and away the most common metastatic sites. But I have seen EHE do a lot of funny things, metastasize to skin, to soft tissue sites. And so it's important if you get, and people have pinged me and sent me their material and so forth. If you get you have EHE, let's say, and then you get a metastasis or another lesion appears somewhere else. It could be EHE and it could be something different. And it's really important to know whether it's a separate disease, just to understand how you would manage now two diseases. A lot of those things turn out to be nothing and they're not that important clinically, but you do want to know. And so I do think that it's important to biopsy these things and understand them.
And related to that answer, we actually had a question come in where someone had initially EHE in the liver, they had a transplant, they're on chemo, and then a lesion showed up in their kidney, and it wasn't clear from the question whether it was EHE or not. First of all, is that something that can happen, and what should they think about in terms of diagnosis when you see sort of another lesion show up after you've gone through treatment?
Yeah. Okay. So kidney lesions are not incredibly common, but we see them in the mice sometimes, and so our mice sometimes will get EHE of the kidney, and it's certainly possible. And so again, you want to clarify that it's most likely going to be a renal tumor, because most commonly what you get in kidney is renal cancer. When things are widely metastatic, though, they can go to kidney, but it would be important to do a cord needle biopsy. A lot of times with kidneys, though, they'll just go in and resect a part of the kidney, do what's called a partial nephrectomy. Very easy to do these days. They can do it laparoscopically, and that's almost the preferred modality because at the same time they're diagnosing it, they get the lesion out and it's essentially curative at the same time. Oh, and they don't like putting needles in kidneys unless they have to.
Yeah. So we had a question come in that kind of gets more to the diagnostic side, or I would say maybe a secondary diagnostic. The question related to trying to determine whether the EHE is indolent or likely to become aggressive or aggressive. And I know during your talk, you'd highlighted like where it is can matter. Are there any other sort of indicators? Are there biomarkers or anything sort of in the queue that might help answer that question better? Yeah,
we're really interested in it. And so the only thing that I can sort of say that, to hang my hat on at this point that might be a pretty interesting is, I'm a cancer geneticist, so I always get accused of being biased, but I am. And yeah, I'm probably pretty biased how I think about things, but it seems that genetic progression is a pretty good story now in an EHE. And I didn't get into it again in my presentation because I really wanted to kind of give more of just an overview and a gestalt. People are certainly welcome to look at our papers, and we publish all of our data. But if you look at humans with EHE, so most of the time, about half the lesions only have a genetic mutation in one thing, and that is the TASCAMP1 or YAP-TFB3. That's half the cases, but another half of them have a small number of changes, a small number of genetic changes. And there's a theme to the changes that we see, and that theme is loss of a tumor suppressor. Typically, that tumor suppressor is something called CDKN2AB, and there is an association certainly between loss of a tumor suppressor and aggressive disease. And we actually modeled that in the mice. So we actually took mice that had the TASCAMP1. We then genetically crossed them. We mated them with another mouse that had loss of CDKN2A and asked, are those tumors more aggressive? And they are, and we published it. And that was the line that allowed us to even make cell lines. We couldn't do it out of the first line. And so I think genetic progression is a story associated with EHE, so that when you lose these tumor suppressors, those tumors tend to be more aggressive. Now, the question that we need to ask ourselves in a prospective trial is, can I biopsy your lesion and see loss of CDKN2A as a way to predict that the tumor is going to be aggressive? The answer to that is we don't know at this point. We'd actually have to very carefully study that to get the evidence to do that. I do think that's potentially a worthwhile study to do, and we're talking about that with a couple of people, how we would actually do that. But there's but we don't today, we don't have a prognostic marker that's absolutely predictive that will tell you, yes, this lesion's never going to progress or metastasize, or it will, or it's in the process of looking like it's going to do something bad and we need to do something. This is a really, really hugely important question, I know, to all of you, and I just don't want to mislead you and say we've got the answer today. We've got some hints though, and I do think genetics is probably what's going on.
All right, something to have future research take a look at. And we're out of time for the Q&A. Thank you so much.